condition.
So acute onset pain during pregnancy. Acute onset pain during pregnancy may be due to a variety of serious conditions. Abrupt onset severe chest pain associated with a widened mediastinum in a patient in a patient who is in late pregnancy or early postpartum period should raise concern for aortic dissection. The risk of aortic dissection is elevated in pregnancy due to hormonal changes that alter the aortic wall due to hemodynamic stress and delivery. Some patients may have unrecognized underlying aortopathy, Marfan syndrome, bicuspid aortic valve that predisposes to the dissection. These patients ST segment elevation in the inferior lead. These patients ST segment elevation in the inferior ECG leads suggest aortic dissection has extended proximally to occlude the ostia of the right coronary artery and can cause myocardial infarction, which is a rare complication of type 1 ascending aortic dissection. Inferior MI due to RC occlusion may primarily involve the right ventricle, causing right causing jugular venous distension and hypotension with clear lungs. Okay, it's not B, coronary atherosclerosis. MI resulting from atherosclerotic plaque. MI resulting from atherosclerotic plaque rupture is uncommon during pregnancy but can occur in patients with premature atherosclerosis. Increased thrombotic risk during pregnancy also contributes. Acute MI would not explain these patients' widened mediastinum. Sharp chest pain, pressure like chest pain is more typical. Okay, this is small VSD. It is, if we look at the box, small VSD asymptomatic, and we know the type like loud, harsh, hollow systolic murmur at left lower sternal border. Chest X-ray is normal. Management is serial echo. most spontaneously close at age 2. On PSD moderate to large comes with respiratory distress, poor feeding, poor growth due to pulmonary overcirculation and high output left ventricular failure, with or without holosystolic murmur at left lower sternal border and loud S2. Chest X-ray shows cardiomegaly and increased pulmonary markings. Management is diuretics and surgical closure. This patient has an isolated VSD, which is most often a or muscular wall defect that creates an abnormal communication between the right and the left ventricle. At birth, the VSD becomes a left to right in VSD becomes a left to right intracardiac shunt due to rising systemic vascular resistance, increase left-sided pressure, and declining pulmonary vascular resistance, decrease right-sided pressure. The symptoms and the outcomes of the VSD depends on the size of the defect, which determines the amount of the excess blood shunted to the right ventricle. Small VSD deliver only a small volume of blood to the right ventricle, are therefore typically hemodynamically insignificant, as is likely the case in this patient. Examination classically reveals a holosystolic murmur at the left lower sternal border, and a loud murmur is often suggestive of small defect due to increased turbulence of the flow compared to the large unrestricted defect. Small VSD close spontaneously by age 2 due to overgrowth of surrounding tissue. In contrast, moderate to large VSD lead to right ventricular volume overload with pulmonary overcirculation and increased venous return to the left side of the heart with left ventricular volume overload and symptoms of heart failure and poor feeding, failure to thrive, respiratory distress usually overlap in the first few weeks or months of life. These defects do not typically close spontaneously, and patients often require diuretics and surgical closure. Got it? Okay, it's OSA. Okay, this patient with hypertension has obesity, nocturnal awakenings, and daytime fatigue consistent with obstructive sleep apnea. Men with obesity are at greatest risk. In OSA, upper airway obstruction due to pharyngeal muscle relaxation during sleep causes progressive hypoxia and hypercapnia until chemoreceptors in the carotid body and brainstem trigger arousal which restores the pharyngeal tone. Manifestation usually includes nocturnal awakenings, daytime fatigue, and reports of loud snoring and apneic episodes from sleeping partners. Patients commonly report difficulty maintaining or falling back to the sleep because nighttime apneic episodes trigger a strong catecholamine response. Many patients with OSA develop secondary hypertension, although the hypertension is often recalcitrant to antihypertensive medications. It is it generally improves or resolves with treatment of the underlying OSA. Nighttime continuous positive airway pressure, other cardiovascular conditions frequently triggered by OSA include pulmonary hypertension, right-sided heart failure, coronary heart disease, and arrhythmia. Got it? Okay. The patient who sustained blunt, the patient who sustained blunt chest trauma, sternal fracture from chest striking a rock and has persistent tachycardia and a new arrhythmia and frequent premature ventricular contraction, both of which are concerning for blunt cardiac injury. Blunt cardiac injury can induce myocardial edema, hemorrhage, and necrosis, capable of causing a spectrum of structural, ischemic, and electrical complications. These electrical disturbances are frequently subtle and asymptomatic as in this patient, but they require further monitoring and evaluation because they may be a sign of more severe cardiac sequelae. Patients with findings concerning of blunt cardiac injury requires 24 to 48 hours continuous cardiac monitoring because most life-threatening arrhythmias occur during that time. In patients with significant findings, arrhythmia, hypertension, heart failure, echocardiography is performed to evaluate for myocardial dysfunction and or structural valvular injuries. Transesophageal echocardiography is superior to transthoracic echo but is more invasive. That is non-intubated hemodynamic stable patient. Transthoracic echocardiography is the best next step. Okay. So its informed consent is the process in which physician provides the information necessary for the patient to make an healthcare decision. Educated healthcare decision elements, essential elements include an explanation of patient's diagnosis, the risk and benefit, both proposed treatment and the treatment alternatives, endovascular and open aneurysm repair, and the risk of refusing the treatment, aneurysmal rupture. It is required that even feasible to cover all the possible potential complications, but the physician must discuss common complication and those that are serious even if they are rare. Okay, option E. The informed consent discussion should include a general explanation of the procedure and the reason is and the reason it is indicated for the patient's particular diagnosis. However, discussion of the various and other indications for the procedure is unnecessary and may cause confusion. Got it? Got it? Okay, it's compartment syndrome. So this patient who underwent femoral embolectomy now has tense swelling of the calf, paresthesia, burning sensation, severe pain that is worsened with passive range of motion and sensory and motor deficits. This presentation is most consistent with the compartment syndrome, a life-threatening condition caused by increased pressure within an enclosed fascial space that limits perfusion of muscle and nerve tissue. It is most common following traumatic injury, long bone fracture, or prolonged compression of an extremity. It may also occur following reperfusion of an acutely ischemic limb ischemia reperfusion injury due to interstitial edema and possibly intracellular swelling. Diagnosis can be made by measuring compartmental pressure, needle manometry, a delta pressure, diastolic blood pressure minus compartment pressure less than 30 millimeter increase indicates inadequate tissue perfusion and is strongly suggestive of compartment syndrome. It is typically more useful than an absolute compartment pressure because diastolic pressure can vary significantly. Systemic hypertension definitive management include emergency fasciotomy. Got it? Okay, it's MR hollow systolic murmur, which is this patient's cardiac auscultation revealing uh, a blowing hollow systolic murmur, which is characteristics of MR, which is characteristics of MR. The murmur is best heard. The murmur is best heard at the apex and often radiates to the left axilla. Common cause of primary MR resulting from dysfunction of the mitral valve itself include rheumatic heart disease, myxomatous degeneration, and infective endocarditis. Uh, secondary MR involves an intrinsically normal mitral valve and can result from left ventricular dilatation or ischemia with impaired ventricular valve motion. Severe MR can manifest with exertional dyspnea fatigue due to reduced cardiac output and can eventually lead to left ventricular failure with resulting pulmonary congestion cough. Okay, this patient likely has severe tricuspid regurgitation. Severe tricuspid regurgitation due to an adverse effect of an permanent pacemaker on the right ventricular lead of our transvenous implantable pacemaker or cardioverter defibrillator passes through the superior vena cava into the right atrium and then through the tricuspid valve to terminate into the endocardium of the right ventricle. Damage to the tricuspid valve leaflets or damage to the tricuspid valve leaflets or inadequate leaflet coaptation can occur, leading to severe tear in patients with 10 to 20% in severe tear in 10 to 20% of the patient. Chronic severe tear typically presents with right-sided heart failure. Patients can have distended jugular veins, pulsatile, tender hepatomegaly, abdominal distension with ascites, and lower extremity edema. Cardiac examination typically reveals right ventricular heave and hollow systolic murmur based heart at the left sternal border. The murmur intensifies with maneuver that increase right ventricular preload, deep inspiration, leg raise. The diagnosis of the tear confirmed by echocardiogram. What have you find in the ECG? Okay, look, can you count the rate of the ECG? Okay, look at the RR. Yes. Okay, from this R to this R. One large square is first large square 300, then 150, then 100, then 75, then 60, then 50, then 40, then 35. Like it's if heart rate is less than 60, it is bradycardia, and there is P wave, presence of P wave, so it is sinus bradycardia. Okay, look at the flow chart first. This is very important. You have to remember this flow chart. Management of symptomatic bradycardia. If pulse is less than 50 per minute and symptoms presence, if the pulse is 50 per minute and symptom present like syncope, if the patient is hemodynamically stable, yes or no. If the patient is not hemodynamically stable, no. Investigate and treat the underlying uh, cause like sinus node dysfunction, acute MI, or medication toxicity. If the patient is hemodynamic stable, yes. Hemodynamic is unstable, yes. If the patient is hemodynamic unstable, no. If the patient is not hemodynamically unstable, then investigate and treat the cause like sinus node dysfunction, acute MI, medication toxicity. If the patient is hemodynamically unstable, yes, then give atropine 1 milligram IV, then it can repeat every 3 to 5 minutes up to 3 milligram total. Persistent hemodynamic instability, yes, initiate transcutaneous or transvenous pacing. That means you need a pacemaker. Initiate transvenous or transcutaneous pacing. IV IV infusion of dopamine 5 to 20 microgram per kg per minute or epinephrine 2 to 10 microgram per minute may also be attempted prior to temporary pacing. Got it? Okay. You want me to read the explanation? Okay. This patient's ECG sinus bradycardia with a heart rate of approximately 30, which explains his recent symptoms of fatigue, lightheadedness, syncope, rate less than 50 per minute is required to cause symptoms. Initial management of symptomatic bradycardia should first involve assessment of hemodynamic stability. Patients without severe hypertension, signs of poor organ perfusion, confusion, ischemic chest pain, acute heart failure, ischemic chest pain, acute heart failure are hemodynamically stable and can undergo close monitoring, while the underlying cause of sinus bradycardia, sinus node dysfunction, acute myocardial infarction, and medication overdose is investigated. Patients who are hemodynamically unstable, such as in this patient with severe hypertension, cold extremity, lethargy, confusion, require urgent effort to cause heart rate. However, however, mm, based on advanced cardiac life support (ACLS), the first step to reduce parasympathetic activity with administration of IV atropine 1 milligram, which can be repeated every 3 to 5 minutes up to 3 doses, 3 milligram total. Patients who remain um, hemodynamically unstable despite atropine should be initiated temporary pacing via transcutaneous or transvenous modality. Alternatively, sympathetic beta receptor stimulation with an infusion of dopamine or epinephrine with an infusion of dopamine or epinephrine should be attempted prior to temporary pacing. Got it? Yes, uh, you can memorize there is a number also like one large square. One large square is the five small square, the bigger one. So one large square, 300 divided by large square, then you can calculate. You can do it by yourself. Like 300 divided by how many large square in here? 1, 2, 3, 1, 2, 3, 4, 5, approximately 6, isn't it? So above 300, below 6. Now you can calculate 100. You can remember one of the question in the world there is they can calculate the rate. Okay, I am showing you from the inner circle. They have something regarding this. Okay, I'm sharing my screen. Sorry. Usually rate is count by RR interval. Okay, okay. Look, I can calculate. So you can see my screen. Okay, from here to here, there are two ways. Like you can do the large square, which is easier. You can do via small square, which is slightly tough, but that one is more accurate. Okay, if you want to uh, if you want to calculate the pinpoint heart rate, then you can calculate via this 1500. Okay, how I am calculating? So one large square, two large square, three large square, four large square, five large square, 300 divided by 5. So how many? 5 6 are. Got it? Okay, now uh, we know that one large square is five small square, isn't it? So you can calculate 5 into 5, that means 25. So now you calculate 1500 divided by 25. So how many? Got it? So this is one way, which is the typical way. There is another way, but in this way to calculate the QRS complex, you need to see the full ECG. But they will not gonna give the whole 10-second ECG. In the question, you will not gonna get the 10-second ECG. If you find the 10-second ECG, this is another again it is easier. If you find the whole 10-second ECG, then you need to calculate number of the QRS complex: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, and 18. 18 into 6, that means 108. Got it? Yes, it is always 6. For QRS, it is 6. Got it? For QRS, it is 6. So yes, if it is irregular, there is another way. Like atrial, you can calculate the rate of the atrial fibrillation also. So there is another way. That one is tough, so you need not to remember. Okay, okay, okay. Yes.